This is a study that was published almost 10 years ago that evaluated over 80 children who had LCH who'd been treated with replacement growth hormone therapy. And this treatment was effective in the sense that their growth velocity almost quadrupled in the first year of treatment. But there was no increase in the risk of recurrence of LCH or no long-term adverse effects. So if you have a child with LCH who's developed growth hormone deficiency, I would encourage you to consider letting your child receive that therapy. This is another question that I'm often asked by families, if my child develops DI, is that something that can be treated with chemotherapy to try and make it go away? Not the vasopressin replacement, but treatment actually for histiocytosis. Is that effective? And the data so far say that that's hardly ever the case. Here are the data. This is a paper a couple of years ago, again from the Nicole Grosz group in Vienna. And of 59 patients that they evaluated with diabetes insipidus, only one patient had any resolution with immediate implementation of therapy. And this patient only had partial diabetes insipidus. It wasn't a fully developed case. So this seems to be a condition by the time it becomes clinically evident, treatment is not going to be effective in terms of reversing the process. So if we can't successfully treat with chemotherapy at the time of onset, if we know a patient is at risk, will chemotherapy reduce that risk? And I think the honest answer in 2007 is that we don't know. But we are trying to find out. And so one of the goals of this LCH3 study that you've heard referred to, and we'll hear much more about in the next day or two, is to answer this question in a group of patients who have so-called CNS risk lesions. So these are patients that have this craniofacial bone involvement. And there's a list of various bones in areas here that I won't go through. But in this study, the question that's being asked, or this part of the study, is will chemotherapy reduce the rate of late sequelae, particularly diabetes insipidus and these other endocrine abnormalities that we've talked about? And so patients with risk organ involvement are eligible to get what is, fairly standard chemotherapy for LCH, vinblastine and prednisone, for a total of 6 months of treatment. And hopefully several years after the completion of this study, we'll have an answer and know what the best treatment is for patients in this situation. Secondly, I want to mention mass lesions very quickly, just to say that they do occur. These are MRI scans that show various areas of the brain where these white lesions that you can see. This is a very large mass that arises from the lining around the brain, the meninges. The choroid plexus or the pineal gland. There are other organs that can be involved. This is quite uncommon. In patients who have these mass lesions, their disease typically responds to standard chemotherapy. And that's really all I'm going to say about that. And then I'm going to finally turn to neurodegenerative disease. So what are the symptoms of neurodegenerative disease in patients with LCH? When should you worry? This is a list of the symptoms that have been described in a number of papers. Patients may have tremors or shaking of the extremities, headaches, gait disturbances, ataxia, which is a loss of balance. That's when the cerebellum is involved, and you can see this MRI, the serial MRIs, two done over time in the same patient, and the cerebellum, which is this part of the brain, has shrunk significantly over time. And so this is a patient with progressive neurodegenerative changes involving the cerebellum, and this patient would be expected to have problems such as ataxia, dysarthria, which is difficulty talking, sometimes visual disturbances, cognitive or problems with thinking or processing information, and even rarely behavioral problems or up through psychosis or hallucinations, although again that is quite uncommon. So there are really two types of neurodegenerative disease that we now recognize in LCH, so-called clinical neurodegenerative disease. And these are patients who will have one or more of the problems that I just described. And in this situation, the condition is not thought to be reversible, at least with currently available therapies. Secondly, there are patients who have no symptoms, but do have findings on MRI scan that suggest that they're developing neurodegenerative disease. The characteristic finding is that on an MRI, the so-called T2 weighted image, one can see either atrophy, the shrinkage that we saw on that prior scan, or changes over time. And you can see here, this is scans all from one patient over a period of 11 years. And on the T1 weighted images, you see no changes at all. On the T2 weighted images, you can see progressive changes in the areas of the brain that light up here. And some of these patients have symptoms or will develop symptoms. Other patients don't have symptoms when they have these findings, but we don't really know what percentage of those patients will ultimately develop symptoms. And so long-term follow-up is key in this condition. We do know that patients who have a mass in the hypothalamus, as a result of DI or in conjunction with diabetes insipidus or growth hormone deficiency, if they have a mass that was at least 4 millimeters in size, the great majority of those patients will ultimately go on to develop some sort of neurodegenerative disease. It might just be radiologic, but it might be clinical. So that's a clear risk factor. Well, what causes this dreadful complication in patients? Again, we don't really know. And so research, basic research to try and understand this process is going to be key to helping these patients. How common is this problem now that we can recognize it? It's been described in a series of studies, and again looking at either very small groups of patients, as small as 25, or series as large as almost 600 patients, we see big ranges in the percent. But in the largest group study from France, about 3% of patients went on to develop symptoms. The Vienna group, which has done the most work with this, found that over half of the patients had that, but that was important to remember upon very intensive testing in a selected group of patients. And so the majority of these patients, Meeling, correct me if I'm wrong, but I think the majority of these patients were completely asymptomatic, but they were getting very close MRI scans. So this is a problem that we're becoming more aware of, I think, as we begin to look more. So if you have neurodegenerative disease in the setting of LCH, what treatments are available? Well, it does not appear that standard LCH chemotherapy, the vinblastine and prednisone and 6-MP that we use to treat systemic disease, has any significant beneficial effect. There was a trial conducted by the Histiocytic Society of Melatonin several years ago, and that had no obvious benefit either. The French group has reported that retinoic acid, which is a form of vitamin A, resulted in not improvement, but at least in stopping the disease from worsening in a small group of patients, about 10. Those studies need to be repeated, and we need to confirm that, in fact, that treatment works for many patients. Dr. McLean has reported that a combination of chemotherapy drugs called vincristine and Ara-C has also resulted in stabilization of disease in some patients. And then finally, immunosuppression, which might work because some people feel that these neurodegenerative changes are related to an immune response to histiocytosis, has not been evaluated. So the bottom line is we don't have an obvious effective treatment for patients who have this disorder.